MaineMOM Echo Learning Series. Today, Kelly Bowden, our kind of regular facilitator, is out on vacation, so I will be filling in. I'm Liz Remillard. I am the MaineMOM Program Manager at the Office of Maine Care Services. Go ahead to the next slide. So for today's session, we're going to be focusing on toxicology screening and guidance from Elaine O'Connor. We will review the benefits and limitations of different types of testing during pregnancy and postpartum, as well as different methodologies that you can use when reviewing the test results. Go ahead to the next slide, please. So for today, we will ask all of you to record your attendance, your name, and which organization you represent in our chat box. It helps us with our CME attendance record, as well as just keeping general track of who's attending our sessions. Today, please mute your lines when you're not speaking, and we do ask everyone to engage in a all share, all learn, respectful dialogue when participating in our ECHO series. It is the standard of our ECHO model, as well as the participation in our MaineMOM initiative. If you're having any technology issues, don't hesitate to reach out to Michaela Rice or Rachel McLean. Callie Bushi is also here to help on this ECHO through the chat, or you can email the MaineMOM at maine.gov email. Go ahead to the next slide. As you noticed when you joined, we are recording this session. We record the didactics and post them to our maine.gov webpage, which I will share how to access that at the end of the session. And if you do not wish to be recorded, we do just ask that you let us know so we can kind of gain understanding of how many people do not like to be recorded. Obviously, when you join, you're consenting to that recording. Go ahead to the next slide. So our presenter today, Elaine O'Connor, does not have any apparent conflicts of interest with the content that she's sharing with us in her expertise today. So without further ado, I will pass it to Elaine to share about toxicology testing.
Good morning, everybody. Great to have you here. I'm going to do my best to keep this in 20 minutes with 5 minutes of questions. Definitely feel free to ask them at the end. I know this is a popular topic. I think of this as it's really important to understand kind of what toxicology testing is and what it is not, and what it gets for you and what it doesn't. I do think it's probably potentially one of the most critical things. I've often testified to results in court, and I say it's analogous to radiologists, and if they didn't have the MRI or the CAT scan to read, that's really the only objective source of information that we have in many cases. So it's important to be at least familiar with it and what the options are at your institution. Next slide, please. So quick overview, some of this is going to be repetitive for folks, but I think you can never hear some pieces of this too much, which is just a reminder that, the standard of care for screening for substance use disorders are validated screening instruments. So we're encouraging folks to use the 4 Ps. Very, very important that the toxicology testing is not sort of that first screening tool that's used. And I do think that that is the case in many places. So the verbal screening is absolutely essential. I'm going to talk a little bit about when you might also get toxicology testing in certain situations, but just a reminder that verbal screening is the standard of care. There's many benefits to testing. Certainly monitoring patients with substance use disorders is a really important piece of it, but it's critical to understand what the limitations are. I'm going to talk a little bit about how to discuss interpretation of a variety of different substances, both those that are prescribed as well as illicit substances. And then I think it's really important to review how to talk to patients about their toxicology screens. And I'm going to try to just use toxicology testing because I'm going to talk a little bit about saliva and urine is probably the 2 most common that we're doing. And just a reminder that terminology matters, which I'll go through as well. Really important to use the right terminology when discussing urine drug screens. We really try to stay away from the word dirty. That just has all these negative connotations in a lot of variety of different ways. So really try to use different terminology, and I'll review that. Next slide, please. So again, toxicology testing requires consent. That's really important. So very important that if you're opting to send a screen that the patient knows that you're going to do this. I ran into this again a couple of weeks ago where I was working with a resident in a different setting, and they had gotten the urine to test for pregnancy. I was talking to them after the patient had left, and I said, "Did you do a drug screen?" And he said, "No, I didn't." And then lo and behold, he added one on, which is really what I don't like to see, because it's not really fair to the patient. They have the right to decline it if they want to. We generally discourage routine toxicology testing for every pregnant patient, just sort of right out of the gate, in part because I think it actually reduces the likelihood that that conversations actually occur. People, I think, become sort of attached to that drug screen. They don't sort of have the conversation. They don't do the verbal screening, and then they get this positive drug screen back, and then they don't know what to do with it. So we don't recommend doing it in every case. And some of the reasons we don't is that, negative test does not rule out sporadic substance use. So again, substances only stay in the system for a certain period of time. So you may miss the use of something. Some substances may be missed, as I mentioned here. A positive test result alone is not diagnostic of a use disorder. That's really important. Sometimes you have situations where maybe a patient has an opiate use disorder, but they're testing positive for methamphetamine, and that may be cut into their fentanyl, so they may not have a stimulant use disorder. So it's really important to note that, if you have a positive test result, it really could be one-time use, or it certainly could be a use disorder. You definitely need to feel comfortable knowing what you're ordering, how to interpret the results. I think there's nothing worse than sitting there thinking, like, maybe you did this or maybe you didn't, and the patient's telling you something and you're feeling kind of not very confident in your interpretation of the results, and like, what do you do with that? And it doesn't feel good all around. There is also some literature that suggests that mandatory testing may be a deterrent to seeking prenatal care, and I think we're trying to get women into treatment as quick and as early as possible. So we really want to do everything that encourages them to come in, not anything that discourages them to. There is a paper that we wrote on this topic that is on the MaineMOM website. I put the link on the end, just around when you might consider ordering toxicology testing. Next slide, please. So these are some of the times when you might use toxicology testing for screening. And again, that's on that document that I've listed. So these are some of the ones that we came up with as a group of professionals doing this work. So someone who has a history of substance use disorder, history of chronic pain that was managed with opioids, and or sort of early refills or lost of or stolen medications that are controlled substances. So it's anything that sort of gives you some sources of concern. It might be that a patient discloses the use of illicit or non-prescribed substances in the past 5 years, or continued use of cannabis or alcohol after learning of the pregnancy. You might have physical symptoms of substance intoxication or withdrawal, or objective indications, something like track marks. Patients who are late to engage in prenatal care, or have fewer prenatal visits, 3 or fewer prenatal visits, or multiple missed appointments, you might decide to screen. I mean, I think it's also important to remember that there may be a number of different reasons that cause a patient to miss prenatal appointments. Could be as simple as transportation. So it's important that you don't necessarily assume these folks have a use disorder, but these may be an indication. And then a variety of different pregnancy complications that I list here. The goal of really providing this document was that if you had a situation where you felt like, I really feel like I need to do a drug screen, but I don't have any way of really communicating with it, I think you could show a patient this document and say, hey, these are some of the indications that I see that would make me feel more comfortable if we were able to do a drug screen. How do you feel about that? And that may give you some information. She might at that point be willing to disclose something that she might not otherwise have done. She might decline it. I think, you have to just go with what the patient wants to do in that moment, but this is something that you can kind of turn to if you're looking for guidance. Next slide, please. So how often should you do it? There's a variety of different bits of guidance about this topic. Should you do it at every visit, once a month? There's not a ton out there in regards to people who have substance use disorders in terms of how frequently you should do toxicology testing. There is a lot out there about, like, if you have somebody in chronic pain management, things like that. I generally do them at every visit, not exclusively. Sometimes people gather a specimen at every visit, but don't send them all for testing. It really depends on how you want to run your practice. One of the things we're looking at is, how often should you be screening a pregnant patient if you yourself are not prescribing the medications? So in a situation where you might have a MaineMOM patient who's on methadone, for example, would you want to be doing toxicology testing? How frequently? And that's an ongoing question that we're looking to sort of document, hopefully, best practices on. Random drug screens are an important source of information, so I think it's helpful to call folks in for randoms, just to be able to document how things are going. Certainly important to consent them to that as part of the sort of enrollment into your program. I really try to use randoms as a source of motivation to some extent, that look, this actually documents that how well you're doing. And so we actually have more objective evidence that you're doing as well as we think you're doing. So I really try to use it as a positive source of motivation. It's important to remember that the duration of time substances remain in the system varies a lot. So I started putting together a table of like amphetamines this long, opioids that long, benzodiazepines this long, and it gets kind of muddy. And we try to figure it out. And I've also feel like with some of the high potency fentanyl that we're seeing, that's sort of very fat soluble, that might go in and out of the fat cells, I'm sort of wondering if actually we're seeing it a little bit longer than we have in the past. So I really tried to think, like, how does this help you on the ground clinically? And I would say that the vast majority of things are out of your system within a week, with the exception here of heavy marijuana use or long-acting benzodiazepines. So if you have a situation where a patient's testing positive for fentanyl, I don't get too wound up about like, was it, Monday or Sunday or Saturday or whatever. But, to be able to, if you're seeing somebody once a week in that interim time between them, if they're using fentanyl, they're using stimulants, cocaine, any of the stuff you're really, really worried about, that is going to be negative at the next visit generally. Vast majority of the time, certainly if you're seeing them every 2 weeks, that would be the case. So this just gives you a marker of sort of how much people are using, how frequently they're using. I don't get too stuck on, they used Monday instead of Tuesday or whatever. That just doesn't really matter to me. But if I have somebody I'm seeing every other week, certainly, and they say, I always say to them, what have you done or what have you used since the last time I saw you in the office, as just sort of a marker in my own brain. So if it's been 2 weeks, they're not, and they haven't used fentanyl within that 2 week period, you should not see that in their system. And so I'll often reflect that back to them. Okay, so when I'm asking what is going to be in your system today, then I'll say, okay, based on our conversation, there's going to be nothing but buprenorphine in your system today. And then try to get them to sort of say, well, but I use fentanyl. And I'm like, when was the last time? And that sometimes helps give that information, get you the most reliable information. So you can also say, what will be in your urine today? Just sort of an opening question. I find that it works better to just review with the patient based on the conversation you've had so far. Okay, so based on what you've told me today, I think there's going to be buprenorphine in your system, there's going to be marijuana, and there's going to be whatever all else. And I think that's the most helpful way to have that dialogue with a patient. If they use the term should, which does happen pretty regularly, it does require additional questioning, because sometimes, they're trying to, in their own mind, figure out like, because there's a motivation, right, to not be detected, right? These folks are concerned about notification to CPS as much as we're saying we want you to be honest with us all the time. They're sometimes wondering, geez, if I don't have to tell them, maybe I'll get in less trouble, that kind of thing. But it could also be, like, that should be it. And then I'll say, well, what do you mean by should? And she'll be like, oh, I'm prescribed Zoloft. And like, she doesn't know what may or may not be in the toxicology testing. So you may just get more information that way. So I just try to ask an extra question. Hey, what do you mean by should? Does that mean there's something else you want to tell me? But sometimes it could be any one of a number of different things. So just ask that follow-up question. It's really important to document self-reported substance use in your notes, so that you're not heavily relying just on that drug screen results. It may have an important implication on the OCFS report. So I really find personally, when I'm doing the reporting process to DHS after birth, that it makes a big difference to them if the patient is really being honest and straightforward about what's going on, versus sort of detecting things in their urine or saliva that they didn't admit to. So it's important to say, like, if they say, geez, I did this and it doesn't show up in their system, you should write that stuff down so you at least have documentation of that, and it may have an important implication. And I always encourage people, please tell me the truth no matter what. Don't try to figure out, like, has it been long enough kind of thing. I already mentioned that terminology matters. Avoid dirty and clean. I usually go with appropriate, as expected, negative or positive. I try to, it's sometimes confusing if you just say negative or positive, because you're probably positive for buprenorphine. I might just say negative for illicit substances or something like that. But important to just use more traditional medical terminology, not dirty or clean. Next slide, please. Critical to know what is and is not in your test, and then use toxicologists as needed. So if you're doing any outside lab testing where you're sending your results somewhere else, absolutely, generally on the bottom of it, say call 1-800-whatever to speak to a toxicologist at Mayo or any other place. Utilize those folks as needed. If you don't know how to interpret something, that's what they're there for. You can certainly reach out to me. I'm happy to help you. There's generally two types of testing. So what we call point of care, POC, you'll sometimes see, which is generally what's called an immunoassay test, which is the results of a chemical reaction. So basically you have the urine, you put something in it, and then the chemical reaction occurs that recognizes it and says, you know, oh, I think this is cocaine, or I think this is methamphetamine. It's chemically similar based on the results of this reaction. There's varying degrees of reliability. I think it's really important to know that. So some tests are really very good. Others are not. So if there's any kind of disputed results, they must be confirmed to be considered definitive. That's really important. So if you get a result that says, you know, cocaine based on your point of care testing and the patient says absolutely not, I did not do cocaine. Okay, fine. I don't have any argument about it. I just say, okay, we're going to send that out for confirmation. We'll figure out what happens, and then we'll have a different conversation depending on whatever happens. It is important to note that there's still no CLIA waive to point of care testing available for fentanyl, as far as I know. I checked that a couple weeks ago. That's really discouraging. We can talk about that in the question period if people have specific questions about that. The upside of point of care testing is that it's generally less expensive. It's available right in that moment, which is helpful. But again, the reliability is mixed. So it's important to know your particular cup, how reliable it is. Confirmatory testing is almost exclusively sent to an outside lab. It's gas chromatography, mass spectrometry. It tests for that definitive substance. So if you get a GCMS test result back and it says, you know, there's 1,673 nanograms of cocaine, you can be sure that there's that much cocaine in the system. There's varying degrees of turnaround time. Sometimes it's 72 hours, sometimes it's a week. So again, know what to expect with your own testing. It is generally quite a lot more expensive, but the results are definitive. So really important if there's some disputes that you have sent that out to determine how much or whether the substance is there and how much of it. You can sort of trend that over time. Urine creatinine, I put some numbers in here. It should be above 20. Specific gravity and the presence of oxidants are important measures. So basically, the creatinine and the specific gravity are measures of how concentrated or dilute the urine is. And if the urine is more dilute, you know, and the cutoff, say, is 200 nanograms per deciliter for benzodiazepines, and you have a very dilute urine, you can see that you may not actually pick that up because the concentration is lower in a very watery specimen. So those are important measures to at least be aware of. Oxidants are things that people add to their urine. So if you're not doing observed specimens, those are things that people might add to try to sort of change what's in the urine. And that should be negative. If it's positive, that suggests they've added something. But it's important to at least be aware of those particular markers as you're doing testing. Next slide, please. Okay, so the urine versus saliva or oral fluid, this is something that we're hearing about more often. Urine, the benefits is it's relatively inexpensive point of care testing is available, and there's sort of the most literature out there related to interpretation. One of the big disadvantages is that it spills and the lid's not on properly. I can't tell you the number of specimens I've sent to an outside lab, but they can't end up breathing because it spills everywhere. Nobody likes that. It can be more easily tampered with in terms of, you know, drinking copious amounts of water to try to dilute your urine, maybe putting something in it. A lot of the stuff that you can buy online that are actually diuretics, again, attempt to sort of dilute the urine. And observed specimens are really not ideal. We wrestled with this for years at Maine General because people who've experienced sexual trauma and you want to watch them pee is very difficult for the patients. It's difficult for the providers. I really don't like doing it. I think sometimes you're stuck having to do it if you don't have an oral or saliva testing option, but it's not without complications and potentially trauma to the patient. So we moved about a year and a half before I left Maine General to saliva/oral fluid toxicology testing. I absolutely loved it. It's easier to collect. You can do observed specimens every time. So like when I was seeing patients individually, it looks like basically a pregnancy test that you stick in the side of their mouth. It kind of sits down next to their cheek and their lower gums. You can do it when they're getting their blood pressure taken. You can, you know, they can talk when they're doing it. It turns blue when it's ready to come out. It can easily be done in a group setting, which is awesome. So if you're meeting in a group, they can all have their sticks in the mouth at the same time. It actually empowers patients because they kind of collect it themselves. They make sure their own labels on it, and it really works well for folks. You also get around that whole, like, I can't pee or I have to pee, which is always hard. You know, patients like, I don't have to pee, or how long do you let them go before they leave the clinic? Or worse yet, I felt bad for my pregnant patients that we'd be telling them to wait till the end of group to pee, and they'd be sitting there completely uncomfortable, their legs shaking because they really have to urinate because they're pregnant, their bladders are tiny. So it gets around all of that. Some of the disadvantages, the detection window is generally shorter than with urine. It's somewhat substance specific. Saliva is actually really good at detecting stimulants, but less good at detecting some of the other things. So it is tended to be a shorter window. I didn't want to give you specifics because I don't think that's really important. The other thing is point of care testing for saliva toxicology is pretty mixed, at least has been my experience. So I don't go there very much. There's other options, serum, nail, hair, but I think that's kind of outside the scope of what we're doing here. Next slide, please. And then I just put this together. This is tiny. You guys can get this slide. But I think one of the most common things that people ask me is like, oh my God, what are the metabolites of this and that? And what do I expect with this and that? So this is a table that I put together with a variety of different resources that pretty much tells you kind of when you see a substance, what do you expect to see in the system? Not all metabolites need to be present. Sometimes you'll see them, sometimes you won't. Generally in situations like fentanyl, you're not seeing much of the actual fentanyl itself, but mostly the norfentanyl, which is the metabolite. We don't see a lot of heroin anymore. I see very, very little heroin. So that used to be very important to explain the differences there. Cocaine, metabolite there, you'll see. And then methamphetamines, I think the other important piece to know is that the methamphetamines does metabolize down to just amphetamines. So that can be confusing for folks, you know, particularly since amphetamine shows up in the same way when it's Adderall or Vyvanse or something to that effect. So this is hopefully helpful for you. I'm sorry it's tiny, but you can blow it up on your screen. And I think that's my